Well, thank you, Ian, for that wonderful introduction. I'm truly delighted to be here. I've been traveling through a few different parts of Europe for the better part of 2 weeks, and I'm trying to get myself shifted into professional mode. If I suddenly stop acting professional, Ian, just kick me or something, and maybe that will knock me back into the right frame of mind. So I'm going to be speaking to you about this concept of the learning health system after I project before you a disclosure that my institution requires me to make. I will actually be referring to this concept, to this learning health community idea later on in my talk, but we all have our rules, and I have disclosed what I need to disclose. How many of you have heard of this concept of the learning health system? Okay, about a third to half of you have. What I would really like to say at the beginning, and some of my colleagues tell me that my talks like this are as much sermons as they are scientific discourse, and maybe this slide is the most sermon-like of them. What I have discovered, and I think what I'm saying is true, is that this learning health system concept really is magnetic and disruptive and transformational. If you think about the three words that comprises it, learning, health, and system, these are all words that have taken on or have always had universally positive connotations. When you put these three words together and you start talking to people about what this learning health system concept is, something almost magical seems to happen. And I do hope to convince you by the end of this talk, as the bottom bullet of the slide says, that pursuit of this LHS, learning health system, as a concept and as something real, something that works in the world, makes good sense for healthcare delivery systems, for states and regions and counties, for public health, for entire nations, and perhaps ultimately for the whole world. This concept of scale that is suggested by this last bullet is going to run throughout my talk. So 3 main points I want to leave you with today. I'm going to share with you some visions of what a learning health system is. I'm going to, as an informatician, really dwell on the idea that the key to achieving a learning health system is by creating an appropriate infrastructure, and this is the informatics problem of realizing a learning health system. And then I'm going to share with you developments in the US, 7 channels of developments at different levels of scale that I believe are synergizing with each other and adding up to really a significant progress toward an LHS for the country. When will we get there? I don't know. I'm not even sure getting there in some absolute sense is even a conversation that one can have. There will be continuing progress, and in a very real sense, the learning health system will never be finished. It will just keep developing. So what is a learning health system, to begin? And in the most rudimentary sense, we can think of a health system becoming a learning health system when it has the capacity to continuously study as a system and improve itself. Where did this idea come from? I did not invent it. There's an old joke from the 2000 presidential campaign where Al Gore claimed that he invented the internet. Al Gore did not invent the learning health system either. It was actually developed in 2007 by the US Institute of Medicine, and the Institute of Medicine has since really developed and propagated this idea through a series of publications called very creatively the Learning Health System Series. And if you Google that, you will have access to PDFs of every volume in this series. The idea is catching on. There have been numerous publications, and I'll come back to this later, possibly the most interesting of which was written by Arnold Milstein, a prominent health policy expert in the U.S., who basically said that one of three things the U.S. absolutely has to do to safely reduce the GDP, gross domestic product, footprint of health in the U.S. is to realize the concept of the learning health system. So now I'm going to begin sharing with you three views of what a learning health system is. They're different, but they're complementary. And I will share them with you in succession. And I'm hoping that the combination of these three views, beginning with what I call a checklist view, will give you a deep sense and a deep appreciation of what a learning health system is. So beginning with the checklist view, this slide could have just as easily been entitled, "Is your health system a learning health system?" And you can tell if your health system is a learning health system by asking yourself if it displays the following 5 properties. Are the characteristics, in other words, the data and the experience as captured in data of every consenting patient available to learn from? Are the results of this learning, the knowledge, immediately available to support decisions by providers, by patients themselves, and by managers and administrators? Is this improvement not bursty? You don't solve a problem and then go into a dormant state until another problem arises, but rather continuous and ongoing. Can you do this routinely and economically with economy of scale to the point that the fact that you're doing it almost becomes invisible? And finally, is all of this part of your culture, meaning that if you went into this health system that you were assaying and asked anybody, why do you do this, they'd say, well, this is just what we do here. This is who we are. So let's now go to the macro view. And if you think about a learning health system, it is something, as I will emphasize later, that can exist at any level of scale. And what would it take for a large-scale learning health system to be sustainable? And you see this by looking at the macro view. So let's just envision a learning health system for this nation you see outlined here. I hope you recognize it. And one property in this macro view that a sustainable learning health system will need to have is all-inclusiveness. Namely, all of the stakeholders have to be involved. And with a crude analogy to nuclear physics, you can think of a sustainable learning health system as being like a stable atomic nucleus. If you take one of the neutrons out, it becomes unstable and decays. All of the stakeholders relating to health must be part of a learning health system in order for it to be stable and sustainable. It must be trusted, and most people now believe it must be decentralized. In other words, the operations and the data, and this is depicted with the cloud, do not happen in one central location, but are distributed across among and across the different stakeholders. And finally, a sustainable learning health system will have to be reciprocal. It will have to have a reciprocity to it, depicted by the two-way arrows here, suggesting that all of these stakeholders will put something in, they will get something out. They won't all put the same thing in, they all won't get the same thing out. But in the aggregate for the system in this macro sense to be sustainable, the value of what is derived from it must exceed the cost of what is put into it. And I will now just re-emphasize that learning health systems can exist at any level of scale. In that macro view, I shared perhaps the largest conceivable system, which is a system that exists at the level of entire nations. But you can have mono-organizational learning health systems. You can have inter-organizational systems. You can have state or regional systems. That's the state of Michigan where I live. It bears something of a resemblance, I now see, to the UK, but you can have nationwide learning health systems, and ultimately we can conceive of a super macro system of systems which would be global in nature. There are many learning health system use cases. There are many different things that once a learning health system is achieved, it can do. And I won't read through the details of these use cases. You can read them if you wish as I go over them at a high level. But at least 3 of the use cases can be bundled under the general concepts of pursuit of best and safer care at lower costs. This is what a lot of people, when they think in the US about a learning health system, think it exists to do. And some call it a learning health care system. And I actually don't endorse that terminology, because there is a much wider utility to the learning health system, which is why I like that use of the term, to include enhancement of public health, and perhaps most important of all, consumer empowerment. Many people who advocate for a learning health system in the US believe that the consumer empowerment use cases, which include this scenario here, where patients facing difficult medical decisions can discover the experiences of other patients like them, which is pretty much impossible now, at least in our country, could be the most compelling and powerful rationale for doing this, although the other rationales are compelling as well. So to complement the checklist view and the macro view of the learning health system, there's also the micro view. And this goes to how learning health systems actually learn. And they learn by creating so-called virtuous cycles around problems of interest. And I think this is a familiar concept. It goes to the notion of a learning organization, which is at least half a century old, but it's a resilient and an important concept, and it's key to what a learning health system actually needs to do to operate, to improve health and health care. And a virtuous cycle begins with a decision by some community to study a problem of interest. They then assemble data. This can be purposefully collected data, or it could be data that is secondarily used from patient records or from other sources. The data are then analyzed, the results are interpreted, leading to the creation of knowledge. And then equally important, there is a feedback loop to these virtuous cycles, which often include the sending of tailored messages to decision makers who may be providers, patients, or managers, and then they will take some action to change in whole, in part, in response to these messages, and that fuels the next cycle over successive iterations of which improvement relative to the problem of interest occurs. I want to emphasize, because this is a very key idea and goes very much to discussions that are going on in the United States, that these virtuous cycles have 2 equally important sides. A so-called afferent side, which can be viewed as big data to knowledge, and an equally important efferent side, which is K to P, knowledge to practice. And learning is the sum of those. It's big data to knowledge plus knowledge to practice. This is important in the US because at the moment, so much attention is being paid to this relative to the amount of attention that's being paid to this. And it's just so important to emphasize on our own side of the pond that we probably are not going to get where we need to go unless we realize that a learning health system needs both an afferent and efferent side that are equally potent and equally effective. So very quickly, you can, as an example of a virtuous cycle, you can think about a problem of interest being reducing falls in nursing homes, and a virtuous cycle to address this problem begins by a community coming together to study falls. They will assemble data, perhaps simplistically presented here as how do we prevent falls, and what results are we experiencing with what we do now. The analysis will associate practices with lower fall rates. There will be a human step here of interpretation. The synapse between the blue side and the red side is intentional. This is not for the computer scientists in the room necessarily, although cycles can work this way, closed-loop machine learning. In this example, there would be a pause here for the interpretation of the results. There would be tailored messages sent back to the stakeholders, in this case, the managers and directors of the nursing home, saying, based on your current practice and what we learned, you might want to consider changing in the following way. They will take action to change their current practice in whole or in part, or some nursing homes may say, thank you for that advice. You have stimulated us to think about yet something different that no one had anticipated that we are going to try. That will lead to a changed state of the system and fuel the next cycle, leading to continuing progress and improvement. So one point I want to make, and I think it's important probably on both sides of the pond, although as I said, it's a big issue in the US. There is so much talk about big data in the US. Is that term used here? I kind of thought it was. The learning health system is bigger than big data, in my opinion. It's a transcendent concept that embraces the concept of big data, but really does, as I said, transcend it. Because big data, as it's described, at least in the US, only addresses that blue side, that afferent side of the complete learning cycle. And the learning health system infrastructure, as I've said before, must support complete cycles. And the danger is, and I'm putting it positively here, the learning health system, in other words, must do this. The danger is it might do this. If we only pay attention to the blue side, we will assemble data, we will analyze data, we will interpret the results, and where will the results go? Not fed back to complete a learning loop, but instead into journals where we know there will be a 17-year latency between the creation of this knowledge in journals and its widespread application in practice. In fact, an anthem of the learning health system is to reduce that latency by whole orders of magnitude of time, 17 years to 17 months to 17 days to 17 hours in perhaps in a public health emergency. I have yet to be able to put this to music, but if we have any composers in the audience who want to make music out of those lyrics, I would be very interested in talking to you about that. So to summarize this first part of the talk, I have presented three complementary views. The checklist view: is your health system a learning health system? See if you can check these 5 boxes. The macro view: let's think about the learning health system as something that can get very, very big to reach what computer scientists call ultra-large scale. And if a learning health system reaches ultra-large scale, perhaps at the level of the entire nation, what are some of the characteristics it will have to be sustainable? And then the micro view, which reminds us that learning occurs through these complete virtuous cycles, each addressing a specific health problem, and learning is BD to K plus K to P. If you forget that K to P, we're going to produce knowledge, but it's going to languish in journals, and that is the problem, the challenge the learning health system seeks to improve upon. So point 2, the informatics challenge of creating a learning health system infrastructure. So you were probably sitting here thinking, okay, this is all very nice, but from a realistic, pragmatic point of view, how actually are we going to get there? And that question can be translated into what you see on this slide as a more specific question: how do we compose, to use a computer science term, a set of learning loops, each addressing a different problem, which could number in the hundreds or thousands, into an efficient large-scale system depicted here as at a nationwide level? Easy, right? Well, you do it by building an infrastructure. And we need to think about achieving a learning health system as fundamentally a problem of achieving an infrastructure. Let's think about what it means not to have an infrastructural approach to this. If you don't have an infrastructural approach to this, by analogy, suppose you had to get 350,000 people per day across a river. Well, one way of doing it that's profoundly non-infrastructural is to build 350,000 rowboats, one for each person. I don't think anybody here would propose that as a solution. The infrastructural solution, obviously, is to build a bridge. And keep that in mind as you think about how we might build a learning health system. We need to build an infrastructure which is analogous to building a bridge, and a very special kind of bridge that's adaptable, as many bridges are. Some bridges in the US were initially built to carry horses and buggies, and now they carry trams and subway cars. We need to build a flexible infrastructure like that. So diagrammatically, this is how you can think of the infrastructure that needs to be built. You can think of it as a ring supporting multiple learning loops. Some, because of the nature of the problem, cycling more rapidly, and others, because of the nature of the problem they are addressing, cycling more slowly. Some problems reveal the results of interventions more quickly than others, and that will contribute in large part to whether a virtuous cycle cycles rapidly or slowly. Key to the understanding of the challenge of building an infrastructure is to recognize that it's not just technology. It's a cyber-social infrastructure which includes people, technology, policy, and process. And the infrastructure we need to build must contain, must embrace, must incorporate all of those elements. So why a platform? Remember, I said earlier in the checklist view of the learning health system, one of the features of a learning health system is this ability to learn and improve routinely. Well, in order to learn and improve routinely, you need to do this with economy of scale. The cost of 100 cycles has to be far, far less than 100 times the cost of one. Without a platform, the rowboat approach, you'll realize no economy of scale. And we have some very interesting learning organizations in our own state of Michigan that look like this. They are learning organizations, they operate learning cycles, but each one is a proverbial tub on its own bottom, and there's no economy of scale. With an infrastructure, with components that they all share, there would be tremendous economy of scale, and if we are going to achieve a sustainable learning health system, back to the macro view, where the value of what is derived exceeds the cost of what is put in, we're going to need this economy of scale, which means we're going to need this platform. And if you can have a learning health system at any level of scale and you're going to build a platform to support it, the scope of the platform has to equal the scale of the system. So a mono-organizational learning health system can have a more restricted in scope platform. A state or regional learning health system must have a larger but not quite so large platform as one that would support a learning health system for an entire country. And finally, to conclude this section of my talk, a bit busy slide here, but this just gives you a suggestion. This could be a whole talk in and of itself of what the components, what the services, the cyber-social components or services of a complete learning platform would have to look like. And the best way to depict this is to map these services against the different stages in the virtuous cycle. For example, collecting data and forming these communities of interest will require mechanisms, largely social and policy, but also somewhat technical for managing communities of interest. Around assembly of data, the platform will have to incorporate policies governing access to data. Then there's the well-known and probably most developed component of the platform, technology for aggregating and analyzing data. Then around to interpretation and results. This component of the platform largely does not exist anywhere I know although one of the projects my department is undertaking is an attempt to create this, and that is knowledge management technology. How do you curate? How do you create a brain for the learning health system so it knows what it knows, and that knowledge can be curated and made actionable? Then we need mechanisms for tailoring messages to decision-making and mechanisms for capturing the practice that is changed or not changed in response to these messages. So building this platform can seem very, very daunting when you talk about it as a whole and look at that ring I showed in an earlier slide and say it consists of people, process, policy, and technology. But when you break it out into different services, I think you can begin to see how we might approach this. I know there are efforts like the Transform project of the EU, which is actually approaching the problem very much along these lines. Now some good news, I think, to close my talk. An update from the U.S. This is flagrantly about the U.S., but coming across the pond and being very familiar with these things, I thought it would be useful to share with you an up-to-the-minute update on what is happening, and I think, as I said, it's very good news with regard to the learning health system. One point I want to make very, very clearly at the outset, and this goes to my 8 years of experience in the federal government, this is not like the moonshot. Building a learning health system is not like the challenge that President Kennedy described in 1961 when he said we'd put a man on the moon by the end of the decade. He stood up there and he knew this could be done, he knew how it would be done, and he knew pretty much how long it was going to take. None of that is true of the learning health system. The learning health system is going to be, at least in our country, an exercise in self-organization and largely bottom-up development. But there are 7 channels of effort, 7 channels of progress that are reflecting this self-organization and development. The first of them is very, very important, words and reports. I mentioned the Learning Health System series from the Institute of Medicine. Another article complementing the one written by Arnold Milstein was written by Victor Zhao, who basically, speaking to academic medical centers in the U.S., and he was the chancellor of the Duke University Academic Center at the time, said basically this is what we all have to become. We have to become learning health systems at our own level of scale. My former office, the Office of the National Coordinator for Health Information Technology, they wouldn't do this while I was still there. But after I left, they basically issued a report last year describing a 10-year agenda for the country, the pinnacle goal of which is to achieve a learning health system. So this is an official policy goal of the U.S. government now. This is a slide depicting the advancement toward a digital system for purposes of documentation of care in the U.S. This describes office practice-based use of digital technology, and we're rapidly approaching 80% use of EHRs. I know in primary care, the UK is way ahead of us, but in hospitals in the US, we've basically achieved 100% digital care. You basically won't find any paper in use in American hospitals. Then there is the development of learning islands. By learning islands, I mean organizations that within their own boundaries and for their own patients have developed those characteristics I described in the checklist view of the learning health system. If you went to these places, John Madison will be speaking from Kaiser Permanente tomorrow, and I think Kaiser Permanente is the best example in our country of a learning island, an organization that within its boundaries and for its own patients across disease types, all of the diseases that it treats, has become a learning organization. But there were other examples like Geisinger Health System and even our own Veterans Administration system. It's lost its way a bit in recent years, but it certainly dramatically improved its healthcare over about 2 decades by adopting methods that would be readily seen as aligned with the learning health system. And then there are complementing the learning islands, perhaps even more interesting, a plethora of inter-organizational learning networks appearing all over the nation. These typically are focused on a specific disease or set of diseases, and just a couple of examples are listed here: the HMO Research Network, the Cancer Link network from the American Society for Clinical Oncology, the Mini Sentinel and now Sentinel network, which exists for doing post-market drug surveillance, the PCORNet by the PCORI, Patient-Centered Outcome Research Institute, and the Cancer Research Network. These are just a few examples. And these complement what I described before because these are inter-organizational learning networks executing learning cycles around a fairly specified set of diseases. The government is beginning, maybe more than beginning, is now dramatically in the business of supporting efforts. The National Science Foundation, PCORI, as I mentioned, the National Institutes of Health, related to the learning health system. And then there is a grassroots effort that has developed since 2012 called the Learning Health Community, which held a meeting back in 2012, identified 10 consensus core values that are at the heart of what a learning health system is. And then we asked the organizations that attended the summit in 2012 and those who didn't to endorse these core values and say these are what we stand for. And to date now 87, this slide is already out of date, organizations, many of which you might recognize here, have endorsed these core values. And these are, the learning health community has no formal membership, but this is certainly the core. These organizations are certainly the core of the learning health community. We also have a mailing list of about 2,000 people that are part of this. And then a research community is coming together around the learning health system. I said earlier that this cyber-social platform is much easier to talk about than it is to build, and there are numerous grand challenges bringing in numerous different sciences that will have to be addressed if we're going to make a learning health system that operates at scale with the kind of efficiency required to achieve the sustainability that will be essential to it in the end. And to this end, I was very privileged to receive a grant from the NSF, the National Science Foundation, to organize a meeting which identified a large number of research questions and began to assemble a scientific community, largely in the US, around what the computer science community, which was very well represented at this meeting, is calling a science of cybersocial ecosystems or cybersocial learning systems. So those are the 7 components or channels of progress in the US, which to my mind are synergizing and bringing us toward, step by step, perhaps inch by inch, a learning health system for this country. So in closing, and related to my 3 major points for this talk, I have shared with you 3 ways of thinking about a learning health system. The checklist view, is your system a learning health system? The macro view, what are the properties of a system at very, very large scale in order for it to be sustainable? And the micro view of these learning cycles, multiple instances of which will be ongoing simultaneously so that a learning health system can actually learn and make things better in the domain of health. Point 2, the key role of infrastructure in the informatics challenge of this. We need to build a bridge, not many, many rowboats, and this is a major challenge. The platform must consist of people, process, technology, and policy. I think this is in some way the next generation challenge for the field of health informatics. And third, I described to you 7 channels of progress in the U.S. toward a learning health system as we move gradually, I believe, in this direction. So thank you very much. I will be around for much of the entirety of the meeting, and if you have questions or comments or anything you would like to discuss with me, I would be more than happy to speak with you. Thank you so much for your time and attention today.